Hey guys, how's it going? Hey guys, good to see you. How's it going? How's everybody doing this weekend? Hey Twinkle. I've got some new question areas and it's getting overwhelming because I got so many questions everywhere, and I was wondering if anybody wanted to audit them and see how they're doing. Like I've got the diagnosis code area, the digestion area, the OBGYN, and orthopedics, where I've been putting new practice exam questions down, and y'all can make sure that they're correct. This is the orthopedic one that I'm working on adding some more questions to. Found a cool guideline just a second ago about when you can bill for pre-op visit and when you can't. So I was adding those questions. Where did that go? Way on down here. Gosh, I got so many. Yeah, down here about when you can bill for your pre-op visit or you can't. When is it included? Those kind of things. But one time my code got written where all these questions, you have to answer all 10 of them before it'll allow you to see the answer. That's really weird. I don't know why it wrote the code that way. But most of the time, the questions are you just pick an answer and it'll immediately show you what the answer and the rationale is. That's the way I like it. I don't like to have to answer a whole bundle of questions. But anyway, I got a blue million of them I've been putting together. This is all orthopedics. And I thought maybe you guys would have fun auditing my questions while I'm auditing the page to get the format correct on my end. Where am I at? This is up at the top. Publish. Let me see if that'll change any at all so that this doesn't have that sidebar. I hate the sidebar over there, but that probably doesn't make any difference. Yeah, there we go. I got rid of it. Oh, look at Twinkle. Gave her a mission. I sent her a couple of emails. Somebody's wanting a YouTube link, but I think she's a little late. I think she's way past her 90 days, but I'm not sure if the link still works or not. Where is this at? And will it help me on my CCS exam? I'm assuming this is on my own website. It's called medicalcodingbyjen.com. I have a free practice area, which is right here for everybody, which is the same thing. You just click an answer and it'll tell you the rationale. And I have quite a few questions there, but if you want a paid membership, I have a bonus membership area right there. If you want to purchase these questions, I got two memberships. One's a duck, one's a goose. The goose is Twinkle's fault because she said I needed to have the $7.99 down, but it's funny. The first plan gets you E&M questions and integumentary cardiology, anesthesia, and diagnoses. The second plan, the Goose plan, gets you all those, plus the digestion, OBGYN, orthopedics, ear, nose, and throat, and oncology, which I'm installing now while I'm on with you guys. And that's just per month, and you still get access to all the questions. And so we're here under orthopedics right now. And yes, this would help with anybody that's taking any kind of medical coding question. I've got everything from anatomy to the actual codes to the diagnoses, what kind of modifiers go in for every section, tons of questions. I'm trying to build from scratch that you guys haven't seen yet. from the guidelines. I'm just going, like, finding every orthopedic guideline in the Medicare, CMS, AAPC, or AHIMA study guides, taking it a sentence at a time and then creating a question and then posting it here. I'm trying to do them in bundles of 10 questions, and I just need somebody to go behind me and make sure, yeah, this is right. I'm pretty sure. Hope so. You never know. I'm not, I am human, so I'm sure there's one or two in here that are like, what? But never know. Even the ones that AAPC writes themselves have errors in them from time to time. None of us are 100% perfect, but I'm doing my best here. And I thought you guys might want to audit them this Sunday while I'm sitting here working away. So again, this is at medicalcodingbyjen.com. I've got the cutest little pictures too for the ducks and the gooses, and then I figured one of these days I'll have a third tier and those will be the swans. I don't know, but we'll see if I ever get all this written out. Where am I at? Okay, my next guideline is what? We're gonna do biopsies in knee orthopedics. I'm just talking to myself while I'm sitting here trying to write some more questions. You guys tell me what you think the answers are to the questions that are on the screen. I'll click the answers and you guys tell me if I wrote the question correct. Hey, from Texas. Good to see you. You're taking yours, Miss Denise, on the 23rd. I've been keeping up with a list of people. Gosh, the notes I've got all over the place. Miss Denise. On the 23rd. They're in Texas. Y'all have had a lot of rain recently. Let's see. We had Pearlie. She passed on the 16th. Phil. Did Phil pass on the 15th? We got Cynthia is going to be doing it on the 24th. Jennifer on the 24th. Pete in June. EXO in July. Ada on the 23rd of June. Val is going to be the 25th of June also. Rose is the 30th of May. Val is the 25th of May too. Sorry. Forgot to change my month. Denise is the 23rd of May. You guys, on your last 10 cases at the end, might have 3 questions per case, and then you might have answers instead of A, B, C, or D. You might have A, B, C, D, E, F, G, H, I, J per question. So not just 4, but you might have like 10 available options. So I need to write some questions like that for you guys. Let me fix your membership, Twinkle. Hold on. Hold on. Don't purchase anything. Hold on. I figured out how to do this because I had to do it to myself. Because I'm like, I don't want to. Okay. Twinkle stop. Wonder which one it is. I wonder which account. You've got 2 in here. All right. Let's see. Let me see. Okay. Yeah. I found you. I'm going to. Hold on. Where do I go? I said I did. What'd I do with it? No, I don't want to sign you on a team. I wanna. Oh yeah. What do I want to do? Manage member. No, that's not it. Add a role. There you go. Refresh your screen and see if you now have access to all of them, Twinkle. And you should be able to cancel your monthly plan too. Because I gave you the role of. Thanks for sharing the live. Thanks for tapping the screen. We got almost 200 likes already. Did that help? Twinkle, did you get access to all of them? And who is my... I know we had some discussions the other night about some people that haven't passed. Right here, these are the ducks. Ducks, Amy, Ada, Sam, Leanne, Marcy, and Elizabeth. One of them has taken it 12 times. I can't remember which one it was. Was it Sam or Leanne? One of them. Oh, good. Good. So right now I'm in the goose. Yes, goose. And these are the orthopedic questions. And I thought you guys would like to pick some answers, and then we'll see what my website says the answers are, and you guys tell me if they're correct or wrong. I'm getting pretty handy at this website stuff. If I could remember how to write the code again the same way every single time I write a new set of questions, that would be nice. It keeps changing. Sometimes I have a little show answer thing. Sometimes I don't. Sometimes it's, I don't know. Hey, Mama Swans, how are you doing? Good, I'm glad it looks much better. There is one area that I love, and I can't remember how I wrote the code. Let me go over there. I think, is it OBGYN? I love the way these are. The font is too small, but look at the dividers between the questions. I love that. I don't know how I made that happen, but that's cool. It didn't last long. I was able to get, I don't know, 30, 40 questions done with the little dividers, and then it all of a sudden went away. I have no idea. And then it came back for one question, and then they turned into this of the show answer thing. I have no idea. I am not computer savvy, but I'm just trying. But I love the little dividers. That looked just so nice and organized, but the font is too small. But geez, I wish I was consistent. Anyway, what do you guys think the answer is for this? My mom's doing great. You will not believe it. She has been completely discharged by her orthopedic surgeon, by home health, and by physical therapy. No one wants to see her anymore because she's awesome. And handled this hip replacement like it wasn't nothing. I know it changes colors, it changes how you answer the questions, it changes the design. I don't know. Some of it's bold, some of it's small. I don't know what I'm doing, but anyway. Thanks, Twinkle. Yes, yes, yes. It was awesome. Now, if we can get my baby cousin all better with his brain cancer, that would be awesome. Him and his wife are in Tulsa, Oklahoma. They don't have any kids. And he's about, I don't know, 7, 8 years younger than me. Maybe a little bit more. Him and his wife are both police officers. And he's been dealing with brain cancer the last 6 months. And he's got 6 more months of chemotherapy and radiation. If we can get him better, we'll be super healthy. Uncle David, my mom's only brother, he's got to go in for a couple of surgeries this year. So we got to help him get better too. But nothing as frightening as brain cancer, Everybody else as well. Everybody's getting cabin fever, ready for school to be over with, so that we can do a little bit of travel this summer. We're going to Tucson, Arizona in June. If anybody lives in that area and wants a meet and greet with me, I'll be in that area around the 19th, 20th, 22nd, somewhere around there. And then we're going to Minneapolis, Minnesota, and the week after that through like July 9th. So if anybody is in that area and wants a meet and greet, I'd love to hang out and visit. My boys are going to a convention. They'll be gone all week while I'm there looking at the city. I'm not even bringing Travis with me, so I'll be really lonely. So if anybody is around that area and wants a meet and greet, I'll have plenty of time. I'll be in the city for like 10 days or something, so Should have plenty of time. Thank you, Mama Swans. Thank you, Great Value. Okay, guys, anybody got their books out? Do you want to do orthopedics? Would you rather do a different subject on my site? We can do any of them. Y'all can audit any of them. Let's see. You know you're going to have these knee surgeries on your exam, especially the 298, 80, 81, 82, 83, somewhere around in those areas. Did I get a new follower? I got somebody. Who followed? You're more confident with my videos? That is awesome. I'll share this out and let everybody know on where's MK and where's Go-Kart. I know they'd want to do some questions. Let's see if we can find them. I had one person contact me about one question and we got it corrected. That was in integumentary, I think. But other than that, nobody has said a word about any of them. And I've put, I don't know how many. I can't even count how many questions are on all these pages. So I don't know if I'm in the thousands yet, but might be. You guys let me know what you think the answers are, and I'll click them for you. Let me go back over here and write some more questions. Where am I at? Okay, I got these. And then I need to add this to the code. This is going to be for when you should report this, that, and the other thing. We got TikTok money on PayPal yesterday or the day before. So excited. We get to give away those YouTube memberships with that money tomorrow when we go live. 1, 2, 3, 4, 5, 6. How many questions was that? 1, 2. Copy that. Ask away if you got questions. I'm just sitting here adding more questions to this pile of questions. And I did all of this site development of all these questions without the IT director's help. Woohoo! He'd have a fit if he saw all the inconsistencies in my font sizes anyway. Oh my Lord, I get fussed at. Y'all have to pray for me. I just added 10 more down here on the bottom somewhere, I think. Yep. These are, oh, nope, they didn't show up yet. These are still the E&M questions for this area. Let's see. Woo, look at all those inconsistencies. They could just keep changing. Is that them? That's them. These are the new ones. I just added underneath these that kind of go over some E&M stuff, but it's still orthopedic. Those are cool. Which of the following conditions must be met for a codable E&M service prior to a knee surgery? Do we need to make the decision for a surgery needs to be made? Hospital requires an H&P to be done. The provider must document medical necessity, or the patient's consent is obtained. Which one? Well, the font is just so tiny for you guys. Let me see if I can't fix that. Here we go. Is that better? Sorry, Mom Swans, did I change the question on you? I know, right? Which of the following conditions must be met for a codable E&M service prior to knee surgery? What do you think? We'll go back up to that top one and see if A is the answer in just a sec. But this one's cool because it's a guideline I just found out about. And it was an actual question from somebody on Etsy whose doctor's office was doing this, and she's questioning, and I'm like, well, I don't know. I don't think that's right either. I don't know. So I went and found the answer for her. What do you guys think is the answer for that one? It's a good E&M question. let's see. Which of the following conditions must be met for a codable E&M service prior to a knee surgery? Consent, documentation, H&P, or decision for surgery? Uh-oh. Make sure you guys can still hear me. Yeah. Microphone's still on. Good. Okay. What is not reimbursable when a decision for surgery is made for a knee? Is it documenting medical necessity, performing H&P, signed consent forms, or answering additional questions? Which is not reimbursable? Probably signing consent forms, probably, right? You can't just make them come in and charge them to sign consent forms, can you? That sounds good. Nope, it's B, performing an H&P. Oh yeah, that's because that's part of the pre-op, right? But you can bring them in and charge them for consent forms? The H&P is not reimbursable. So up here, which of the following conditions must be met? We know it can't be H&P. Got to have documentation of medical necessity? Yeah, that one. B. What about a provider? Let's go back up to the top and see if her answer for A is correct on that one. It is correct. Good job. Perfect. Which of the following conditions might prompt a provider to do a diagnostic surgery? Diagnostic means they don't have much of a diagnosis. They're going to go in and do a look-see sometimes. But a knee, I think all you got to do is match up the knee with the knee surgery. Rotator cuffs are in the shoulder. Ankle sprains, nope. Hip, nope. So it's got to be meniscus, right? Yeah. All right. We're having a diagnostic with the nerve. Which one of these codes does the diagnostic with the nerve? Anybody know? A again? Why am I thinking 7-6? I'm having to get out the book. 298. Seven six has the nerve thing in it. SYN. So does the 75. It's limited. You'd have to know. And then the 7-6 is major, where you're doing the whole membrane removal. And we're just doing a biopsy. So we may not even be doing the 7-5. You might be right, because if we're just doing a biopsy, is that included in the 70? Oh, you're right. It does say with or without The biopsy. Ooh, my first thought was 76. Good job. Good job. Perfect. I quit second guessing you guys. Y'all know better than me. Which modifier should be appended to indicate the procedure was performed on the left knee? Oh, easy peasy. Another A. Yep. And then which diagnosis code would be correct for left knee effusion? Bring up the next two for you guys since y'all will be in the same area. You can tell me what the answer is for both of them while I write some more code. Let me think. No, I'm going here. I'm going there. My code looks different for some reason. Why? Ah, oh no. My answer, all 10 questions before you see the answers came back. That's why. Why did it write like that? Oh, good gracious. Y'all got the answers for the next two down? Here we go. Publish. And then the crazy thing is every time I add a new question, I have to go into the mobile version of my website and fix it too, because you can't just put it on the website version of your website. You have to go in and edit it, all of it on the mobile version. I forgot to do that the last set of questions. Dang it. There we go. Publish. Go back over here. You're bad at ICD. Are they all A again? Did I make every single answer A? There's no way. Did I? Yep. And then this one, 6-2 and 6-5-6-2. I guess so. So weird. Why might a provider decide to perform a nerve biopsy during a diagnostic procedure? To investigate inflammatory conditions, to repair something, to treat something, or to remove something? It's got to be just to investigate, right? Because it's just a biopsy. Yep. Okay. What documentation is necessary to support a claim for a diagnostic thing? Family history, dietary, no. Blood results, nope. A again. Detailed note. All right. If a provider performs a diagnostic knee thing, finds no further action is necessary, which CPT code is used? It's got to be just the 70 again, right? Yep. All right. If we're doing surgical, we're not doing diagnostic anymore, we're doing surgical, including a lateral removal and cartilage shaving. On the left, what do you think the answer would be, and what modifier would we be using? What do you guys think on those two? You hear Travis in there just screaming away in his room. B and C? We know C's right down there. Let's see. 81. Perfect. It is B. Good job. What about this? If we're doing the surgical drain, what would we be? We're doing surgical. And then a diagnosis to go with it. right, guys, did you get an answer for both of these? Hey, Meek, how's it going? Let's see, we got A for number 1. What about number 2, diagnosis code-wise? 71 is correct. Good job. And then we've got another CPT one. What would you be doing if you were removing a loose body? And this one is for a complete tear of the left knee. Jen, thank you for the heart me. Are you the Jen that is going to take their exam on the 24th in 5 more days? I have a Jen doing it then. I just don't know which one she is. You got a glitter badge. That is too fun. Thank you for the almost 2,000 taps and the shares of the live, letting everybody know we're on. Very good. Boy, Sammy. Anybody want to take a guess as to what the answer is? Anybody at all? B and A. Yep. Perfect. All right. Let's see. If we got anything worth a darn, let's see. We've got some radiology and codes that could be done with the knees. If a provider is doing an exam of the right knee with supervision and interpretation, what would be the code? 60, 62, 64, 80? And then when a provider prefer using, what am I trying to say? When might a provider prefer using an MRI over a diagnostic scope? Why would they use an MRI and not scope the knee? When the patient is a child? Thank you for the tappy taps. Thank you, thank you, thank you. We did get to the 2000. We could move on and do some OB and delivery, if y'all'd rather, if knees are boring. Let's see, I want to see how my last questions I just added look like. They're not there yet. Let me see if they're there now. Hit the refresh button and see if they show up. Ooh, the questions. Yep, there's the last ones I just did a few seconds ago. Which condition is characterized by spinal cord compression that may require spinal fusion? Gotta be that one. Well, could be that one. That's muscle, isn't it? Oh. This set, you gotta answer all 10 before you see what the answers are. I don't know why the code went and wrote that way. It's crazy. I like it when you can just do one at a time and it tells you what the answer is. I like that. I like doing that. Alright, we've got a whole ton of questions we could be doing. Although I rearranged the whole side here for me, I can't see. Let's see, we could do OB and delivery. Maybe I got some cool questions here. I don't know how far. They got small font. When is it appropriate to report lysis adhesions separately from the main surgery performed in OB/GYN? So I went from the very beginning of the chapter of the female reproductive system and went through every set of codes in order. So this is just the very start, and tried to find guidelines and examples of those codes from the very beginning of the book to the end. So I'm not done with all of these questions yet, but started out for sure. Is it when the adhesions are soft, extensive, to access, We do have B for the first one, but we have C for the second one. A patient undergoes abdominal surgery, has dense pelvic adhesions that are documented, and took a very long time to lyse. How should this be coded if the adhesions are on the ovaries? They're saying 58740. Because you have to look for ovaries, fallopian tubes, whatever, in the CPT descriptor. Under what conditions should you avoid reporting 58740 for adhesions during a surgery where OBGYN removed the uterine fibroids? When the adhesions are on the fallopian tubes, when they're dense or extensive, when they're from a different site. This came from a document from AAPC about some of the most missed concepts that they had put out. Some of their Q&As. So I wrote these into questions that mirrored their CPC exam off their Q&A. That's where I got this info. Should be super helpful for the exam. It's wanting to make sure that I am a human. Verification complete. We have detected inactivity. Refresh. Well, it's okay, good. There we go. B is correct. Good job. And then the next one you said A. B again. Pelvic adhesions. Pelvic adhesions are bands of fibrous scar tissue that can be formed in the abdomen and pelvic. During surgery or infection, these adhesions can connect organs but are separated, leading to complications in the pelvic. Inflammatory. Which adhesions can lead to complications in pelvic inflammatory? It's not the ones on the fallopian tubes, which is crazy. It's the ones that are on the pelvic area. Trick question. Very crazy. During a scope, the OBGYN notes dense adhesions and significant time. What modifier should be used? Supporting the 22 modifier. What would they need to document? History of previous surgeries, the time and effort, the insurance information, or the anesthesia used? That one should be easy. There we go. B for that one. Let me get this smaller because y'all can't see all the question. There we go. There's 3 questions. I don't know what he means by the small battery is dead. I don't know what that means. I didn't know the Tesla had more than one battery. I thought we only had one battery in that car. We got a small battery? Hey, Black Queen, how are you doing, Miss Scorpio? Good to see you. These are some of my practice exam questions I have on my website. Was just seeing if anybody wanted to try to answer them. See if anybody wants to audit them and see if I'm correct. While I'm working on adding some new questions to the website. Oh, I did it wrong. That's why. No, we're going to delete that. Delete. And then we'll go here. I'm doing good. We can do CRC right now if you want to do a bunch of diagnosis codes. I've got a whole page of those that I wrote, too. It's not HCC, like finding your category for your diagnosis once you've found it. That's part of the HCC, but half of the exam is knowing your guidelines with the diagnoses. Which one is coded first, which one's coded second, those kind of things, which I've tried to put a ton of those in here. You know, when a patient's here for one thing, but they have a history of this, which could be related or not related to it, what diagnosis code is picked for that particular visit. Gets crazy, gets so crazy. I'm fixing to take the CRC course, and I will of course add those onto a page here, but these could be super helpful for you. You want to do some of these. We have a cone biopsy, dilation and curette, past history, and today, we have concerns over reoccurrence. Her recent pap smear showed atypical granular cells. So we're going to do a cone biopsy and dilation and curette. So would we have 2 diagnoses or 1? Would we have symptoms and post status, like history of? Would we have symptoms with the cancer? Would we have 2 statuses or history of, or 1 cancer code? Something like that would definitely be on the CRC exam, for sure. Oh, you haven't even got your books yet? Oh my. Fixing to take that CRC course myself. I got one more test of the CPCO course, and when I take that test, it's just the final exam. Then I can get rid of that course and purchase the CRC course. I can only have one at a time right now. They won't let me buy multiple at the same time. What is a 12? Is the 12-volt battery just a square little thing? Model 3. Oh no, that's like a regular battery, huh? Oof. Where is it at? don't know. No, not if the course is not free. Absolutely not. If the course comes free with your purchase exam attempt, which they do that sometimes in June or July, they give away a free course if you buy the attempt to pass the exam, then great. But if don't purchase that course at whatever it is, $2,000, no way. No. I got plenty of practice questions for you. I mean, unless you got $2,000 you want to spend and you don't, and it ain't gonna hurt, you know. Some people, you know, if you got free grant money or something like that, you know, but don't spend your grocery money on that for sure. Some people, you know, I mean, sometimes they find grants and stuff or go through their town or state unemployment or employment agencies, and they can get it covered sometimes. So that's pretty cool. So there's a lot going on in this example. You have to think about, why is the patient coming in today? They're coming in because they had an abnormal pap smear. Not because they have technically the history of the cancer before, but they had 2 years of negative pap smear results. So they've been healthy so far, but their last pap smear came back abnormal. So your Z codes are for status, meaning they're here for a wellness exam or they're here for an abnormal test result, right? So we know our answer is C with this one. It would be the 2 Z codes. Or did I put, I thought it was the Z codes. No, it's the R code for the abnormal test findings. Oh, boy, my brain is bad today. Thought it was the 2 Z's for the abnormal test results. What's the Z12? Why am I thinking that? I know we did this one recently in one of my lives. Was it the R code for abnormal results, or isn't there a Z code for the abnormal results? Yeah, maybe I'm wrong. Encounter for Z12. Z12 is encounter for screening for malignancy, and no, that's not why they were here. That would be, yeah, that would be if they were coming in with no other issues. That's correct. That is wrong. A is the correct answer. Oh, so if they were coming in for the previous visit, the one where they had been for the past 2 years negative, and she comes in for her routine pap smear, that's where the Z and the Z comes in. But since she had an abnormal pap smear and she's coming back because she has the abnormal pap smear, that's where the symptoms come in, and then the Z code. Ooh, even I can get these wrong. They're awful. All right. What about pain and malignancy? His treatment is for cancer that is metastasized to the lung. The patient is here today for a nerve block. So what are we going to code first? Is it going to be the cancer code or pain code? That's what they're wanting to know, is which one would go first. We've got G89 down twice, A and C. Then it's just a difference between the two cancer codes, 78 or 34. I'm currently taking the TPC course. I absolutely love it, but actually a lot more than $2,000. So CPC, I forgot to mention it was more than $2,000 for me because I took the prerequisites too. I've seen people pay like $18,000 for their courses or something. Yeah, it gets crazy. Where can you help me with coding with modifiers, like doing office visits and infusions? Well, if you're doing an office visit, which is separate and has a separate visit, you're doing a separate history, physical exam, you're looking in the ears, down the throat, you're checking out their history of diabetes, whatever, then you just bill your office visit with your 25 modifier, and then you bill your procedure for your infusion, right? Anytime you're doing an office visit with a procedure, you know you have to have your modifier to go with that. Cancer code would go first. If today's visit was only to mitigate pain, she's not being seen for cancer today, technically. She's being seen by a pain management specialist, right? There's a guideline attached to that. We have two answers that start out with pain first. The G89.3. It's the same answer down twice. That's usually a very good hint as to what the answer will be. Then you just need to know that C34 is a primary cancer, where C78 is in the back of the cancer section, where all the metastasized cancers are usually at. Anything from C7, C8, C9 are usually metastatic cancers, where C1, C2, C3, all those are primary cancers. Sorry, I clicked on it, didn't mean to. But that's why A is the correct answer, is because this is a metastatic cancer. You know you're going to be a C78 no matter what. And there's only two answers with that. And then you just need to know which one goes first. And pain goes first if that's what they're being seen for today. Trying to get this to where it all fits onto one page and is bigger for you guys. But that's, yep. Patient presents to the office with ongoing history of diabetes, which has been controlled with insulin. During the exam, the physician notes a gangrene has set in due to diabetes of the left great toe. Patient is recommended to see a surgeon for the treatment of the gangrene. What would today's visit be diagnosed with? E10 or E11 is the first thing that you need to deal with. That'll get you down to a 50-50 shot. My Uncle David is at a Duran Duran concert. Aww. I know he's in so much pain too. He hasn't had his corrective surgeries yet. And I know he's just trying his best to hang out with his beautiful wife, Miss Tara, spend time with her. That's so sweet. Thank you, thank you, thank you. Everybody like C? B was correct. We were E11 this time. What's our differences between our E10 and E11? Be sure and write these examples inside your ICD-10 book. It's super helpful to get them down. That way, if you see these examples again, you've already got them written in your book, and you can pick out your answer really easily. E10 is what? Type 1 diabetes. E11 is type 2 diabetes. Did they tell you that the patient was type 1 diabetes or if they were type 2? Nope, they just said that the patient was on insulin. That does not mean that they are always going to be a type 1. My mom was on insulin at one time and she's a type 2. So they have a guideline that says if it does not specifically say that the patient is a type 1 in the chart for today's note, that you have to bill for type 2. So you would have known that B or D were your only options. Then you just needed to know if you were a 0.2 or a 0.4. When coding a patient who has primary malignancy of thyroid cartilage that was completely excised a year ago, which of the following statements is true? Why do I not have a D on this one? I only have A, B, and C. When the cancer is surgically removed with no further treatment, there's no evidence of existing primary code, code Z85. When further treatment is provided and there's evidence, we're going to code Z85 first and then the C32. Any mention of excision, invasion, or metastatic to a code site is coded D49 and a Z85. What do you guys think about this one? Rosalind, Lee, Swans. Good to see you guys here. Mari, Twinkle, you still around? Hey T, good to see you. I bet it's A. Yep. Easy peasy. Scooch you down. See if there's any that are fun. 7th characters. Multiple sclerosis. Fungus and sinus infections. Oh, sounds terrifying. 72-year-old male who's been using steroids a long time for those bilateral cataracts. What ICD-10 codes are coded? We've got 3 of them with the X5 at the end. Only one of them doesn't have that. 2 of them are H25 and 2 of them are H26. Might be helpful. I wonder if this battery thing is replaceable under warranty at Tesla or... Took them 2 days in town to find an 11-year-old who ran away from her mom. I think it was Friday. They finally found her, like, maybe it was Thursday afternoon. Yeah, it was Thursday afternoon. They finally found her. Nope, it was Friday afternoon. It was. Friday afternoon around 11, she ran away from her mom and they found her under a porch. Saturday afternoon around noon. Boy, they had so many people in town just scouring the desert for her. She's an 11-year-old. People didn't sleep. People were out running around looking for her. But so happy that we found her. That was great news. We had Amber Alerts going off on our phone like every 4 hours. It's crazy. Me too. It's like the whole town just kind of stopped. And we were all like, where in the world? It's 102 degrees outside. It seemed like it was 3 days, but I guess it was just one very long 25 hours she was gone. Gosh, it seemed like it was so much longer. What would be the answer for our steroid guy? Yeah, it is so hot here. Right now it is almost 7 p.m. and it's 97 degrees. So it was up to about 103 today. Starting to go down now. We'll get up into the 120s most of the summer. It gets crazy hot here. I mean, sand melts at 117 degrees, so even just going to the beaches around here, around our Colorado River, are crazy because even the sand will melt to your feet. It's hot. I don't know why anybody decides to live here. It's hot. It is hot, hot, hot. It's like, yep. Everybody's like, but it's a dry heat. Yeah, there's no humidity, but it's hot. It's like a microwave. Another A was correct. All right, let's see. Any kind of questions area you guys would like to see at all? Anesthesia, OBGYN, cardiovascular, integumentary, E&M questions? What kind would you guys like to do? Yeah, we hit a record of like 136 a couple of years ago. We have 2 central units outside on our house. Like, most people have those boxes with the big fans outside, you know, the central units. They have one of those attached to their house. We have 2. And then we have these 2-ton backup units. We just installed another one. And so that makes us have 1, 2, 3, 4. We have 4 backup 2-ton air conditioners just in like major rooms. Like the master bedroom has an extra backup one. The living room kitchen combo area has one. Our garage where we put the cars has to have a 2-ton air conditioner because everything in the garage would just catch on fire just from the heat. Everything would melt. Your tires to your car, if you leave them outside on the sidewalk out here, it just melts the rubber on the tires, and you get it's like your wheels aren't round anymore. They go flat on the side that is left on the sidewalk. So when they roll, there's a flat spot, and they roll again in a flat spot. It's like you're going up and down, up and down, up and down. It gets crazy. So we have to air condition our garages just to keep things from melting. It's insane. I don't have medicine done yet. Hadn't made it there yet. Just have E&M, integumentary, cardiovascular, anesthesia, diagnoses, digestive, OBGYN, and orthopedics. Do some E&M, maybe? Let's see. Check on some of these newer questions that I've just recently wrote. Physician provides hospital care to a patient who received no prior care from the physician or any other from their health care group during this admission stay. Which of the following codes should be used? Are we doing admit, subsequent, consultation, or a discharge? A physician provides care to a patient who has received no prior care. God, it sounds like AAPC wrote this question, but I know they didn't. Provides hospital care. Very little information, Jennifer. During this admission/stay. So are we doing it in admit? Or is this part of their stay? Subsequent is admit, apparently, is what I'm looking for. Blank are used for initial hospital care provided to a patient during the first with no prior evaluations. That would be true, right? If no one from the group has ever seen that patient before, this has to be an admit. It can't be the subsequent visit. Yeah, that's right. All right, what about this one? A physician provides hospital care to a patient who has previously received observation care from another physician within the same group of practice. This care was delivered on a prior date at the same hospital stay. What would we be doing? Initial hospital care, subsequent, a consultation, or a discharge? Ooh, look, I labeled them for you. That's mighty nice of me. Now we're doing subsequent. Yep, that's a subsequent. Good job. A physician covering for an unavailable attending physician sees a patient for the first time during an inpatient hospitalization stay. The covering physician belongs to the same group but is of a different specialty. How is this encounter coded? Are we doing admit, subsequent, consultation, or discharge? Thank you for the tappy tap taps. Almost 5,000 likes. And the shares. The covering physician belongs to the same group, but is a different specialty. B is the correct answer. Even though the covering physician is seeing the patient for the first time, this encounter is considered subsequent hospital care because the patient is under the ongoing care of another physician within the same group of admission. The fact that the covering physician is from the same group but of a different specialty does not necessitate using initial care codes or consultation codes, as they are continuing care on behalf of the original attending physician. Physician is covering for an unavailable physician. So the physician must have seen the patient prior, then had to go home. This physician comes in, follows up with this patient. They're of the same group, so it's a subsequent visit. Oof. And why did it change again? I have no idea. Under our new 2023 E&M guidelines, which scenario allows for the use of admit hospital care codes? Is it multiple providers from the same specialty see the patient during admission? The patient has been seen by another physician of the same specialty in the same group during the stay. A patient has not received any professional services from the physician of the same specialty or subspecialty, blah, 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 and advanced nurse practitioner assisting. Yeah, no, we're not doing that. Which scenario allows for the use of admit codes? C is correct. Only if the patient has not received any professional services from anyone in their group can you do the admit. If an advanced nurse practitioner assists a physician during a patient's initial hospital care, how should their services be billed according to the 2023 guidelines? NPs can bill separately for their services. It is considered the same subspecialty as the physician and they can't bill, or they need to use different E&M set of codes, or we just add the 25 modifier. B is correct. Good job. When a patient is admitted to the hospital as an inpatient or to observe status from another site of service, which modifier should be added to the initial site of service to indicate a significant separate identifiable service? Somebody was asking me about modifier questions. Here's one, two, probably several of them in a row, since I like to work with guidelines that are connected very closely together. Okay, did I add these questions and answers to my site? Can't remember. What additional elements? I made a YouTube video going through the entire lab and path section, letting you know which codes are important, what notes are important for your medical coding exam. Be sure and watch that if y'all haven't. I posted it, I don't know, Friday or Saturday. Super helpful. That's still under orthopedic. I think so. Let me know in chat if you got any questions. Happy to help. Y'all let me know what you think the answers are. Almost updating 10 more questions for the orthopedic section. Got some anatomy thrown in this one, this set. And luckily the code did not make me have to answer 10 questions before you see all the answers. I hate that when it does that. I'm too impatient. I like to know if I got the answer right or wrong instantly. One question at a time. It's the way I like to do the questions. All right. What have y'all got? Maybe A. Anything that's E&M related will either be 24, 25, or 26, or 27. Patient admitted to the hospital from another site. So if we're billing for an ER visit and an admit to the hospital all in the same day, what modifier do we use? 25, 26, 24? You can look at your side cover of the front of the CPT book. They're all listed there. 24 is unrelated. 25 is significant separate. 26 is professional component. '27 is multiple outpatient hospital E&M encounters on the same day. But one of them's inpatient, so that wouldn't work either. It is C, 25. What is the key difference between the 2023 policy and the CMS policy regarding admit hospital care codes for patients being admitted from a different site? CMS allows for separate billing for services. CPT code requires all services provided in conjunction with the admission to be part of the same initial admit care. CMS considers all services provided by the physician on the same date as part of the admit, or CPT does not require a 25 modifier. Gotta love how they both compete with each other, but we're supposed to pay attention to both of them. Where's my shoes? C is the correct answer. CMS considers it's all to be part of admit, but CPT says you can bill them separately with the 25 modifier. To avoid double dipping on admit observation care claims, what should coders ensure when coding for multiple providers from the same specialty and practice? Each provider bills separately for their own services. Only one admit hospital observation code is used per patient. Use a different E&M code set for each provider, or apply a 25 modifier to each provider's claim. What do you guys think? Yeah, I like B too. B is correct. Good job. If a physician sees a patient in the ER for a related problem on the day the patient is admitted to observation status, how should their visit to the patient be billed? Do we bill them as initial hospital care, emergency, subsequent, or discharge code? What you doing, Sam? Move it. Move it. You awake, ready now to harass everybody? What do you guys think? They're hard. Yeah, because I wrote them. So, yeah. I mean, if you can answer all these correct, you know you're beyond ready for the exam. That the CPC exam will be easy for you if you can do any questions that I wrote, that's for sure. If a physician sees a patient in the ER for a related problem on the day the patient is admitted for observation, how should the visit be coded? ER visit, but they've been admitted. How can you bill ER when they've been admitted? Subsequent care, well, they're admitted to observation. They've not been admitted to the hospital. I don't know if that makes any sense. And we're on the day of admission. So if we're on the day of admission, is that subsequent? It would be if it was a specialist. But let's see if that's admit. Subsequent care is correct. According to the guidelines, if a physician, NP, or PA sees a patient for a problem or related one in the ED on the day of admission to observation, their visit should be coded as a subsequent care, not initial care coded. Good job. Perfect. That guideline is, I can tell you what page number. If you have the 2024 book, that is page 17 and 18. Right there, the last paragraph and then the first paragraph on the top of the page, that's where that guideline's at. When change did, what change did CPT 2023 make regarding the descriptors for the admit hospital care? They deleted the codes entirely. They kept the codes, but changed the descriptors to include observation. They merged the codes into a single code, or they required all three components to be used for the codes. No worries, honey. It's hard. Extremely hard. Indeed. B is correct. Good job. A provider needs to select an admit, hospital, inpatient, or observation care code for a patient encounter that includes a medically appropriate history and examination with medical decision making of moderate complexity. Which code would we use if the total time on the date of the encounter is 60 minutes? 55 minutes must be met or exceeded. So which answer? Select an initial admit. So you know your A, B, or C, because D is subsequent hospital visit. So which one is for 60 minutes? B is correct. Good job. Under the new guideline, what is no longer required when choosing admit hospital? Medically appropriate history, examination, 3 out of 3 past family or social PFSH, or MDM. Excuse me, Kat. Excuse me. Probably A, right? Well, no, we got to have our history. We don't do C anymore, right? The 3 out of 3. Mm-hmm. Three out of 3 past family and social history is no longer needed. C. When coding for a patient admit to the hospital from another site of service, which set of codes should be used for discharge? Good job, honey. Prescribing, let's see. Discharge is either 38 or 39, right? See? Those are our discharge codes. Yep. How should a non-admitting provider bill for a follow-up visit to a patient who was seen in the ER and later admitted to observation status by another provider? Ooh, this question's on the exam. Hello, EXO. You're doing your exam in July. I was talking about you earlier. I was hoping you would be able to come on. Y'all are just playing around on my website, practicing some questions that I wrote, seeing if they're correct or wrong. While I add more questions to it. What do you think the answer is for this one? I bet you are. Just get your notes done, and then 2 weeks before you're ready to take your exam, stop making notes and just practice exam questions. You can add a little bit of notes in there about the practice questions that you're doing, but other than that, don't go, in there and keep highlighting a bunch of stuff and adding to the anatomy. Just the last 2 weeks, practice all the exam questions you can find. I believe. How should a non-admitting provider bill for a follow-up visit? We're billing for a follow-up visit on a patient who was seen in the ER that was later admitted to observation that day by another provider. That's that same guideline on the bottom of page 17 and the top of the page on 18. It is subsequent care, I believe. Yep, B, subsequent care. Super important question to know. Anytime any provider is seeing a patient as a follow-up on the day that they were admitted and they saw them at admission time, something like that, it's always going to be billed a subsequent care visit. Oh, that was the bottom of the page. Go back up. Let's do some of these. Critical care services. They should be easy because they're just minutes. You just got to watch how many minutes. 74 minutes of critical care time would be billed. No worries, honey. You'll get it. She's taking her exam on Tuesday. Pat Ray on the 21st. James's birthday is tomorrow. My little big man will be 15. Your son turns 20 today? Aww. Our little Tauruses, they love their creature comforts of home. Page 25. Mm-hmm. A is that one. Let's see. Twinkle says I got something mixed up somewhere. Some sort of formatting. Where are we at? We are supposed to be at included in the time E&M services. What's the following scenario? Double billing? Some formatting issues. Let's try this one. When billing for an E&M service where both the physician and the non-physician provide part of a visit, determines who should bill for the service. The provider who performs the initial part of the visit, the provider who spends the most total time with the patient, the provider who performs the most critical part of the visit, or the provider that does the last part of the visit. James gets to spend his birthday in Vegas going to one of Travis's doctor appointments to get a mole removed. Travis had this mole on his chest since he was born. The doctor said that it was just a scratch from the scalpel from the C-section and then it would go away. But it was a mole. It never went away. And when he is propping the girls up on his chest to lift them and cheer, their foot goes on that one spot on his chest. So their feet are constantly hitting this thing and it's driving him nuts. So had to wait like 3 months to get this appointment. So get it removed. I could probably do it myself, but take him to the doctor and let them scar him if he's going to get a scar. And get that removed tomorrow. And I think next week the school's going to be so mad at me because tomorrow they're starting state testing. They're out of school. The last day is Wednesday. I don't know why they put state testing off to the very last minute of the last week anyway, but I'm just going to have to get over it. I have to pick him up around 11, so hopefully he can get enough done between 7:30 in the morning till 11. We got to be in Vegas at 1:30, so it's a 2-hour drive. C, B, B, the one who spends the most time, not the one who does the most critical part. Not crazy. Which CPT code are used for initial hospital inpatient observation care and discharge on the same date of service if the patient stays less than 8 hours? If you don't have a 2024 CPT book, you're missing this little chart that would tell you this answer. Indeed, good job. It sounds crazy. I mean, what if one doctor does the heart replacement, but the other one does, I don't know, the nerve replacement? They spend 15 hours replacing the nerves when the heart doctor spends 4 hours doing the heart replacement. The one that stood around and did all the nerves connections gets to bill for most of the procedure, even though the heart is the more, I don't know, urgent thing. You really need your heart pumping and working more than you need the nerves firing correctly. I don't know. But it's funny. They got rules for everything. Which code would we use for somebody who was admitted and discharged all in the same day, but less than 8 hours? B. Is that correct? There's my little charty. Less than 8 hours. Medicare patient? Do we need to say Medicare? Our little chart says, yep, less than 8 hours. We're gonna bill A, right? Is there a reason? Codes require 2 or more visits by the same physician if we're going to bill that. If we're going to bill B, we got to have 2 or more visits documented by the physician. Our chart says A is the answer. I need to have probably some more information in here if I'm going to pick B as the answer. Because our guideline says codes 99234, 3536 require 2 or more visits on the same date, of which one of the visits is initial admit and the other being a discharge. Oh, wait a minute. For a patient admitted and discharged on the same visit, meaning one visit, you bill 99221, 99222, and 99223. If I'm going to pick B as an answer, I have to have in here that there are 2 or more visits. I need to fix that question. So sorry, I'm just playing around and seeing. I think I need to fix that question. because it's unclear whether the physician saw them once or twice or whatever, because that one's unclear for you guys for sure. Here's some more split shared visits. What does the introduction of a split or shared visit entail under the 2021 guidelines? The visit must be provided by a physician exclusively. The visit can be divided between physicians. Only the time spent with the physicians can be selected, or all clinicians involved can report their time separately. Ooh, let me go to my editor. Let's see if I can't edit that question. If I can find it in all this mess. There it is. Impatient. So I just went in and fixed that question. Let me show you how it would be really tricky for you guys the way I write it anyway. I got so many questions in this area. Okay, down here. That's it right there. But I fixed it. Gotta refresh again. Somewhere around in this area. Did I forget to hit publish? Maybe? Publish? Okay. We're still on page 19 of your CPT book if you're in the 2024 version. Now I changed the question to say which codes are used for an initial inpatient admission with observation care and discharge visits on the same calendar date when they are less than 8 hours. This is where that chart comes in handy, but also you have to remember your guideline up here that says that these codes require 2 or more visits on the same day. They require an admission and another one for at least being discharged. On my note right here, I have now the word admission. Then I put the word with observation care. So that means the doctor came in, saw the patient, and admitted them. The doctor came back and saw them for observation care. And then the doctor came back again for a 3rd visit and did a discharge visit. So if the physician saw them 3 times in one day, even though it's less than 8 hours, what this lovely little chart says, what would be the answer? That's where this one comes in play for being the answer B. And then we had our split visits. B is the correct answer for that one. Which statement best describes modification to time as a factor for E&M services? Time is explicitly included. time is no longer used, time alone may be used, or time spent for services is separately. Do I do stuff just about billing? You're welcome. I don't know what that question means. Are you looking for anatomy questions? Good night. Oh, about fraud and abuse? Yep. Guidelines. I'm going to be making a whole bunch of questions about guidelines. I love writing that kind of stuff in my CPT book too. I think it's super helpful prior to your exam to have a list of, got a ton of stuff, but I have a particular area where I can go in and I can look at just my examples of fraud right there. And then this is just my examples of abuse. Just all in one location, super handy dandy. That way I know where to go and find it. This is all my differences in all the different audits that they have, perspective, retros, baseline audits. When I did the CPMA exam, I just wrote all the different types all here on these beginning pages right before the E&M section so that it was super handy dandy right before the exam. I think that's a really great technique to do, is find as many practice questions as you can and write those examples down. Even for the different types of modifiers that you might use, what kind of examples would you need? Like, example for the 22 modifier was 2 hours spent doing lysis adhesions. For our increased procedure, you know, any kind of different examples, write them in. That way you've got it, just a reference during your exam. Super helpful. Yeah, I've been on for almost 3 hours. I cannot believe it already. Wow. Sundays go by so quick. thanks for the follow. Hope I can help you out. You're welcome, great value. Time alone can be used. It can be. C is the correct answer. What else do we have? We have a patient who has low back pain and skin tags. They come in for a chief complaint of right side low back pain after trauma from sports, a motor vehicle accident, also left shoulder pain from a dislocation that happened. They're diagnosed with a right thigh sprain, left shoulder pain, skin tag removal, and lumbar spine sprain. Procedures included 2 excisions of the upper eye. What if you did not have time and you did not have MDM? What level visit would you bill for this? 12, 13, 14, or 15? You didn't write them any prescription, it doesn't look like. All the way from A to C. And a nope. No guesses? Another C and another B, or their first B. B and C. Dawn, thanks for the follow. B is correct. Island girl knows her stuff. Let's see. This is an established patient. Documents supports a lower level E&M. We would have needed a modifier and the procedure code, but we were only billing for the complexity of the MDM. So the risk of complications of the doctor not doing anything, not ordering any tests, not ordering any meds for this patient, is pretty low. They have an acute uncomplicated illness or injury. You'd kind of think some of this might be chronic since it's been going on for a while, but their physical exam showed no pain, very little tenderness. Did have one area of pain in the SI joint, but there was no tenderness or anything in the shoulder. Had normal range. Low risk of complications because maybe they told them over-the-counter meds, but those are rough. Those are the hardest ones. What about when you do have time? We have a physician documents an established office visit for 20 minutes and additional 35 minutes for an individual psychotherapy. Would we bill 99213 plus the psych code 32? Or do we bill a new patient, 99202, with the 3-4 psych code? Do we only bill for psych, 3-7? Do we do MDM and a 3-2? What do we do? We do have an established patient, so we know right off the bat B goes out the door. Do you combine the time and just bill the one code, or what do we think, guys? Anybody take a guess? When you're doing psychotherapy and a regular office visit, there's a guideline to that. You can't utilize time as your boy, your hair looks terrible. I'm talking to students too, so be nice. Go eat some cereal. Can you put the dishes away from the dishwasher? Those are clean. You have tons of cereal. You did not eat all of it.
I ate all of it.
No, that's not the only cereal we have here, baby. You had Cocoa Puffs too, and the Frosted Flakes. You can't use time to do your office visit. The only one that can do time when you're doing two different visits is psychotherapy. Psychotherapy holds the exclusive rights to time when you're doing it. So you have to do your other visit not by time. You have to do it by MDM. So that's why C is the answer. So remember that if you're doing split visits, 2 visits on a patient, and one of them has to deal with therapy trumps time, if that makes sense. They get to pick time. And then the other visit cannot use time. We have to use the MDM. Can't use time for both visits. Can only use it for one. And therapy reserves the right to always be able to use time exclusively, because we have another way we can bill office visits. I hope that's helpful. Since I have been on for 2 hours and 58 minutes, that is a long time, and Twinkle is going through here and auditing these things and sending me tons of corrections, I'm going to skedaddle, but I hope this was super helpful. We have lots of practice exam questions now on my website. I'm still working on adding more. We've got E&M, integumentary, cardiovascular, anesthesia, diagnoses, digestive, OBGYN, and orthopedics up. I'm working on finishing up ear, nose, and throat, and oncology too, which will be out really, really soon. And I don't know what time I will be back from Vegas tomorrow to take Travis to get this mole removed. Hopefully it will be back in time to do a live on TikTok. But it is James's birthday, and I know he's hoping to go out to dinner. I don't know. I haven't planned anything, haven't done anything. I have no idea what we're going to do. But I'll keep Twinkle informed to let you guys know when and if we'll go live tomorrow. Definitely Tuesday live on YouTube, so look out for that. We'll do 2 hours of practice exam questions for sure on YouTube. So I will see you guys later. I hope this has been helpful. Thanks so much for hanging out with me. I really appreciate it. Mary, Met, Lee, Yoli, Aaron, Winkster, Jig, Twinkle, of course, Rose. Thanks so much, guys. I hope this is helpful. I will download this and post this up on YouTube also. And I will be following you guys. Good night, T. Good night, Great Value. Good to see you too, Island Girl. Really a lot of fun working with you guys. I hope this is helpful, and I'll be following you too on TikTok too, so I always try to hit the follow button for everybody so I can see y'all's TikToks too. See you later. You're taking your exam in the morning, Brittany? Oh my. Best of luck. What can I tell you really quickly? Because I could spend 3 hours on here. Travis, that's not putting away the dishes. What are you doing? What are you doing? Which is true about adjacent tissue transfer? How is oxygen, poor blood, got into the lungs by the superior vena cava? If you get that question, look for that answer, superior vena cava. CRNA supervises an IUD implant. What connects bone to bone? Rule out appendicitis. T cells and the thymus. The pairing of corns off of 4 areas. How would you code that? Lots of people dying in the ER. What was that? ERMD, 75 minutes of critical care, dead on arrival. You just need to go look at the time. Adjacent tissue transfer, the 1400 codes, which is true, page 94 on the 2023 CPT book. Which gland only does the T cell hormones? An excision of a sacral pressure ulcer, destroying 14 AKs. How would you code that? When to use the microscope code or not, that 69990 code. Be sure you know which codes it can go with and which codes it can't. There's a whole list and it's parenthetical. Intersex surgery, female to a male. Check out those codes. Percutaneous vertebral augmentation, rhinoplasty, two vertebral body lumbar, partial thyroidectomy with a parathyroid removal. IUD insertion question, IUD removal question, a quick look OB ultrasound, an OB blood panel, the splenic flexure, a duplex scan. How does CO2 blood get back to the lung? That's that superior vena cava thingy. What arthocoronary arteries? Direct bilirubin. No idea what I was writing there. Gastroenteritis secondary to NSAIDs. Which is coded first? 90-day global period. Which of these procedures has 90 days? QX, AA, QY. Moz, 3 lesions. I think one of them has 6 slides. So you know you'll need that 15 code. 3 different lesions means your second code, which is the 14 or the 12, will be times 2. Electrolyte panel and a basic panel. Can you code those together? And be sure you know about the G0105 code and abortions, whether they're spontaneous or elective. Lord have mercy, that's enough. Screening colorectals, yes. Bless your heart and best of luck. I hope to hear from you tomorrow that you passed. And I hope something I said made a difference. Yeah. Best of luck. Search me out. Let me know how you did. Brittany, I hope this is helpful. Choose some peppermint gum, peppermint tea, anything. Peppermint is said to raise your scores no matter what on any test that you can take. Yellow and green are good colors to wear or be around when you're taking an exam. And best of luck. I hope this is helpful. I'm going to skedaddle. I will see you guys later.